concerning the open reduction and stable fixation of isolated displaced talar neck and body fractures that was published in JBJS.
So I'm here for AO North America Journal Club discussing talus fractures with Dr. Eric Lindvall in his JBJS 2003 paper regarding the open reduction internal fixation of talar body and neck fractures. Thanks so much for being with us tonight.
Thank you for having me.
I'd like to start out by asking, what was the prompt for you and your colleagues in Tampa for performing this study?
So really, I think it really had to do with, in the treatment of these fractures, it was kind of unclear in the literature as to what the true incidence of osteonecrosis versus post-traumatic osteoarthritis were, because so many of the studies had limited follow-up, or they had non-displaced fractures, or they had associated articular fractures. So our goal was to try to clean that up and kind of look at the isolated displaced fractures of the neck and body, and then kind of report on the results of that.
In your findings in the paper, what are the major takeaways that you, to this day, almost 20 years later, find to be the key or most important takeaways from your manuscript?
So I think it has to do with probably the long-term outcomes that we were able to find, because the study had a minimum of 4-year follow-up. So it gave us kind of a benchmark as to what's expected long-term. And we found that in the displaced fractures, at least, they really end up with 100% end up with osteoarthritis, some form of it, and then also with some form of discomfort in that ankle. So knowing those two things, that helped with our future counseling and such like that. The treatment piece, I think, piece we did find, we were able to maybe not have to rush out of bed in the middle of the night to fix these with the intent that it went up with AVN in the future. Although in this time frame, we were trying to do that because that was kind of the reported procedure or technique to avoid the AVN. So after the results of this, we kind of were able to look at it and maybe say, hey, you know what, some of these maybe can get reduced and spit in a splint overnight and get done next day.
So that's something that for you, from the development of this to how you practice today, has changed in terms
Correct.
of.
Yes.
Is there certain key phrases or things you try very hard to convey to your patients at the time of injury and as well in follow-up? What type of things do you say to them with respect to outcomes?
Yeah, I think that's important, because their expectations, once known at the beginning, help the treatment course and their outcome, just because of the way they frame it and look at it. So part of that discussion, it really is about the AVN, about the osteonecrosis possibilities, and then the fact that the arthritis does form long-term in some form. We try to explain to them that will occur, whether it's symptomatic or a real problem for you, we don't know. But if you were a runner, maybe you want to rethink that and start taking up cycling or those kind of things, but not with the intent to decrease their activity level, but maybe modify it so they're not hampered more by the injury.
Within the body of the manuscript describing the methods, it's discussed that there was CT scans obtained in addition, and possibly MRI. Can you talk about the use of advanced imaging post-operatively that you used in the manuscript, and if you use it now?
So personally, I don't do a lot of post-operative CAT scanning. I think the radiographs are kind of indicative of their symptoms, meaning if we see some arthritic change or if we see some type of AVN collapse. But I think the MRI initially in our study, we were using them because we were trying to make sure there wasn't a form of AVN and trying to use titanium screws and those things to avoid more artifact. But I think over time, I'm not sure that's as relevant, because the x-rays can truly find the arthritic changes. We can see the collapse of the talus. So routinely, I don't personally get post-op CAT scans. I think the pre-op setting, it's really important to do that, just because you can assess and plan the surgery. But I don't find a need personally to get them often post-operatively, only because we can see those changes on x-ray.
Gotcha. You mentioned the use of titanium screws. Could you touch on the fixation used in this manuscript and how yours has either stayed the same or evolved in the last several years?
Yeah, so back in this day, obviously cannulated screws were the technique, and the plates were kind of a thing of the future still. And now I know a lot of people that have published on this have gone to plate fixation in certain instances. I think it's very valuable in certain situations where there's a lot of comminution and you're afraid of over compressing and ending with a varus angulation or a deformity. But I personally haven't used a lot of plates because I think they are a little bulkier and they have some other symptoms from those. So I personally have been able to stick with the screws. We'll put in the side that's maybe not as common at first to avoid the overcompression, and then a position screw on the opposite side where the collapse may occur. So I haven't personally used much in the plating realm, but I know others have and had success with it. So I guess to answer your question, I still stuck with the similar fixation type, but I know others have been successful with the plating.
Gotcha. We just touched upon fixation. Is there anything with this manuscript that after you and your colleagues, after it was accepted and published, is there anything you would look back and do differently to help add to the strength of the paper, or to do differently?
Yeah, I think in hindsight, we would have liked to add more patients, right? I mean, I think most studies would say that, but in this instance, others have published with greater numbers. And I think we ended up with such a small number because we tried to turn into just the isolated displaced fractures. So we ended up knocking out a lot of cases because they had associated neomals, calc, some other thing that may cloud that true incidence of osteoarthritis. Yeah. So we tried to limit it. So in hindsight, we could have lengthened it a little bit, waited a little longer, and pulled in more cases, which would have been nice. Another thing would have been possibly to use a different outcomes measure. We use that, the ankle scoring system, the AOFAS, and we probably could have gone to the SF36. I think in hindsight, we commented on that in the paper. Yes, but that may have been a little more relevant outcome measure according to our current standards. So.
Gotcha. Is there, in terms of future research, do you think that there's a specific area that you would like to see answered in the literature regarding these injuries? Or specific question, excuse me?
Yeah, so I think, I guess to that question, in a bigger sense, I think gross anatomy is one of those things where once you kind of discover it, I don't think there's a lot of change that occurs with that. Hopefully not. I know we're still evolving in some fashion, but I don't know how much our anatomy is. But with that being said, I think the rest of the literature body, just because technology changes, techniques change, I think that's always relevant to continue publishing on items like this that may, in the end, do better with plates or some other thing that comes about at a later date. So to answer your question, I think there's always relevance to new studies, either to confirm what we thought before or to show different changes in the future. Okay. I think gross anatomy studies are one of those that may not be as relevant to that, but yeah.
Gotcha. And then when you have these injuries come in, what are things that what are the top 3 things you ask or make sure that your residents or trainees know in California regarding these injuries?
So the displaced fractures, the Hawkins 2 and 3s, we go after those reductions in a closed fashion if they come in the evening time or nighttime, because OR access gets tricky and things. So we'll try to do those in the morning. But I think a reduction is important. Although we say in here that maybe timing is not as critical, I think we could have added the fact that a reduction of that fracture would be beneficial. I can't believe leaving it unreduced would be of any benefit. So, and most of them will reduce reasonably. Sometimes the body will stay spun in the joint, but I think a lot of times the neck will come in reasonable alignment, subtalar joint can reduce. So I think that's a beneficial move that we try to get done early and avoid just leaving it displaced overnight.